शुरू करें।
My name is Dr. Fiza Makbul. I am MCP.
आहिस्ता बोलना, ऊंचा बोलना जरा।
Assalamualaikum. My name is Dr. Fiza Makbul. I am MCPH trainee at Hamid Latif Hospital. Today, the topic of my presentation is ovarian hyperstimulation syndrome. I think move नहीं हो रहा। थोड़ा सा please कर दे minimize।
इसको नीचे और मिनिमाइज कर दें इसको, और ऊपर कर दें, ठीक है।
आगे बोल चला गया फर्स्ट लाइन पे।
हाँ,
Ovarian hyperstimulation is a complication of fertility treatment which uses the pharmacological ovarian stimulation to increase the number of oocytes and therefore the number of embryos available during assisted reproductive techniques. OHSS can occur in the women undergoing in vitro fertilization, IVF, or the ovulation induction with injectable medications. Less often, it can occur during the fertility treatment taken by mouth, such as clomiphene. Most of the cases of ovarian hyperstimulation syndrome are self-limiting and require supportive management and monitoring while awaiting the resolution. Women with more severe OHSS may require inpatient treatment to manage the symptoms and reduce the risk of further complications. Introduction and background epidemiology. Exposure of ovaries to the human chorionic gonadotropin or luteinizing hormone following the controlled ovarian stimulation by the follicle stimulating hormone FSH underlies the most of the causes of OHSS. Exposure of the hyperstimulated ovaries to the human chorionic gonadotropin leads to the production of pro-inflammatory mediators. Chief among them is the vascular endothelial growth factor VEGF. But a variety of cytokinins are also likely to be involved in the pathogenesis and the clinical features of OHSS. Occurrence of ovarian enlargement with the local and systemic effects of the pro-inflammatory mediators, including the increased vascular permeability and pro-thrombotic effect, is responsible for the clinical features of the OHSS. Increased vascular permeability leads to the loss of fluid into the third space, manifesting as ascites or less commonly the pleural or pericardial effusions. Women with severe OHSS demonstrate hypovolemia with a typical loss of 20% of their calculated blood volume in the acute phase of OHSS. Accompanying this hypovolemia is reduced serum osmolality and the sodium. Incidence of OHSS. It is known that the incidence of OHSS varies between different types of fertility treatment, with the treatment involving greater degree of ovarian stimulation being associated with a higher incidence. In the cycles of conventional IVF, mild OHS has been estimated to affect around 1/3 of the cycles, while the combined incidence of moderate or severe OHSS varies from 3.1 to 8%. Certain patient and cycle characteristics also increase the risk of OHSS, which are women with the previous history of OHSS, women with the histories of PCOS, increased antral follicle count, and high level of AMH are an increased risk for the OHSS. The outcome of the treatment also influences the incidence, which is higher in the cycles where conception occurs, compared with the cycles without conception, and higher still in the cycles resulting in the multiple pregnancy, highlighting the importance of the role of endogenous human chorionic gonadotropin. Diagnosis. Diagnosis of OHSS is made on the clinical grounds. The time of presentation following the trigger injection divides the patient in two groups: early OHSS and late OHSS. The early OHSS usually present within 7 days of the HCG injection and is usually associated with an excessive ovarian response. Late OHSS typically present 10 or more days after the human chorionic gonadotropin injection and is usually the result of endogenous HCG derived from an early pregnancy. Late OHSS tends to be more prolonged and severe than the early form. Okay, this is a relevant history from a woman is suspected of suffering from OHSS. The important points which are to be asked during the history are the time of onset of symptoms relative to the trigger injection, medication used for the trigger, either it was human chorionic gonadotropin or gonadotropin releasing hormone agonists, number of the follicles on the final monitoring scan, number of the egg collected, where the embryo is transferred and how many? And is there any history of polycystic ovarian syndrome? Symptoms. Symptoms of OHSS are abdominal bloating, abdominal discomfort, pain, need for analgesia, nausea, vomiting, breathlessness, inability to lie flat or talk in a full sentence, reduced urine output, leg swelling, vulval swelling, associated comorbidities such as thrombosis. Okay. The examination and investigation from a woman with suspected OHSS. In general examination, first of all, we'll look for the dehydration and edema, which includes pedal, vulval, and sacral edema. We'll check her heart rate, respiratory rate, blood pressure, body weight. On abdominal examination, we'll assess the ascites, palpable mass, signs of peritonism, the girth. On respiratory examination, we'll assess for pleural effusion, pneumonia, pulmonary edema. Investigations will what we'll get are full blood count, hematocrit, which will indicate a hemoconcentration, C-reactive protein, which will with which we can assess the severity of OHSS, urea and electrolytes, which will show with which we look for hyponatremia and hyperkalemia. Serum osmolality, there will be hypoosmolality. Liver function test, there will be elevated enzymes and reduced albumin. Population profile, there will be elevated fibrinogen and reduced antithrombin. Human chorionic gonadotropin to determine the outcome of the treatment cycle, if appropriate. Ultrasound scan, ovarian size, that it will show ovarian size, pelvic and abdominal free fluid. And we'll consider ovarian Doppler if there is a torsion suspected. Other tests may be indicated, they are ABGs, D-dimers, ECG, chest X-ray, and computerized tomography, pulmonary angiogram, and VQ scan. Differential diagnosis. These include pelvic infection, pelvic abscess, appendicitis, ovarian torsion or cyst rupture, bowel perforation, or ectopic pregnancy. Okay. Proposed RCOG classification for the severity of OHSS. We can divide OHSS into 4 types. These are mild, moderate, severe, and critical OHSS. Okay. In mild OHSS, there will be abdominal bloating, mild abdominal pain. Ovarian size will be usually less than 8 centimeter. And in moderate OHSS, there will be abdominal pain, nausea, vomiting may or may not be present. Ultrasound evidence of ascites and ovarian size is usually 8 to 12 centimeter. In the severe OHSS, there will be clinical ascites, hydrothorax may or may not be present. Oliguria, about 300 ml per day or less than 300 ml per day or less than 30 ml per hour. Hematocrit will be more than 0.45, and there will be hyponatremia, there will be hypoosmolality, there will be hyperkalemia and hypoproteinemia. Ovarian size usually is more than 12 centimeter. In the critical OHSS, there will be dense ascites and large hydrothorax. Hematocrit will be more than 0.55. White cell count will be more than 25,000 per ml. There will be oliguria or anuria, thromboembolism, acute respiratory distress syndrome. Organization of services. Of the services. The fertility clinics should provide verbal and written information concerning OHSS to all the women undergoing the fertility treatment, including a 24-hour contact telephone number. All the acute units where the women suspected with OHSS are likely to present should establish a local protocols for the assessment and the management of these women and ensure that they have access to the appropriately skilled clinicians with experience in the management of this condition. Licensed centers that provide fertility treatment should ensure close liaison and coordination with acute units where their patients may present. Initial assessment. The women presenting with suggestive symptoms of OHSS should be assessed face-to-face by a clinician if there is any doubt about the diagnosis or if the severity is likely to be greater than the mild. The aim of initial assessment is to establish the diagnosis and grade the severity of OHSS. Outpatient management of OHSS. Outpatient management is appropriate for mild to or moderate OHSS and in the selected cases with severe OHSS. Women undergoing the outpatient management of OHSs should be appropriately counseled and provided with information regarding fluid intake and output monitoring. In addition, they should be provided with contact details to access the advice. NSAIDs should be avoided as they may compromise the renal function. Thromboprophylaxis with low molecular weight heparin should be given to the women with severe OHSs who are being managed on the outpatient basis. Paracentesis of the ascitic fluid may be carried out on an outpatient basis by the abdominal or transvaginal route under the ultrasound guidance. There is insufficient evidence to support the use of gonadotropin releasing hormone antagonist or dopamine agonist in treating the established OHSs. Women with OHSs should be provided with verbal and written information about their condition. However, it appears reasonable to encourage the patient to drink to their thirst rather than set an amount. Fluid intake of at least 1 liter per day should be advised. Outpatient management may be aided if the patients are able to maintain fluid input and output charts. Urine in output of less than 1000 ml for 24 hours or a positive balance of greater than 1000 ml over 24 hours should prompt medical review to assess the severity. Monitoring of the patients being managed on outpatient basis. If the signs and symptoms of OHSs are worsening, the patient should be reviewed urgently. These include increasing abdominal distension and pain, shortness of breath, tachycardia, hypotension, urine output less than 1000 ml in past 24 hours, positive fluid balance more than 1000 ml in past 24 hours, weight gain, increased abdominal girth, or increasing hematocrit which is more than 0.4.5. Inpatient management. Hospital admission should be considered for the women who are unable to achieve satisfactory pain control and unable to maintain adequate fluid intake due to nausea, or they may show the sign of worsening of OHSs despite the outpatient intervention, or they are unable to attend for outpatient follow-up or have critical OHSs. Inpatient care of the woman with OHSs. Multidisciplinary assistance should be sought for the care of the women with critical OHSs and severe OHSs who have persistent hemoconcentration and dehydration. Features of critical OHSs should prompt consideration of the need for intensive care. A clinician experienced in the management of OHSs should remain in overall charge of the woman's care. Women admitted with OHSs should be at least assessed once daily. More frequent assessment is appropriate for the woman with critical OHSs and those with complications. Symptoms can be relieved by using analgesia, antiemetics, avoiding NSAIDs, and the medications which are contraindicated in the pregnancy. Management of fluid replacement. Fluid replacement by the oral route, guided by the thirst, is the most physiological approach to correct the intravascular dehydration. Women with persistent hemoconcentration despite volume replacement with intravenous colloids may need invasive monitoring, and this should be managed with anesthetic input. The diuretics should be avoided as they further deplete the intravascular volume, but they may have a role in the multidisciplinary setting if the oliguria persists despite adequate fluid replacement and drainage of the ascites. Management of ascites and effusions. Indication for the paracentesis. Severe abdominal distension and abdominal pain secondary to the ascites. Shortness of breath, respiratory compromise secondary to the ascites and increased intra-abdominal pressure. Oliguria despite adequate fluid replacement secondary to the increased abdominal pressure causing reduced renal perfusion. Paracentesis should be carried out under the ultrasound guidance and can be performed abdominally and vaginally. Intravenous colloid therapy should be considered for the women who have large volumes of the fluid removed by paracentesis. Management of the risk of thrombosis. Women with severe or critical OHSs and those admitted with OHSs should receive low molecular weight prophylaxis. Women with moderate OHSs should be evaluated for predisposing risk factors for thrombosis and prescribed either anti-embolism stoppings or low molecular weight heparin if indicated. In addition to the usual symptoms and signs of venous thromboembolism should be suspected in the women with OHSs who present with unusual neurological symptoms, even if they present several weeks after the apparent improvement in the OHSs. Surgical management. Surgery is only indicated in the patient with OHSS if there is a coincident problem such as ovarian torsion, ovarian cyst rupture, or ectopic pregnancy. OHSS, relation of OHSS and pregnancy. The pregnancies which are complicated by OHSS may be at an increased risk of preeclampsia and preterm.
Shall I? Actually, this has been a detail of ovarian hyperstimulation syndrome. This is not a very common condition and usually is managed in ART units or ART departments. Since it is associated with ovarian hyperstimulation, ovarian as is called ovarian hyperstimulation, not syndrome, but superovulation. What do you call that? Superovulation of ovaries, or treatment for superovulation. And then there are certain patients who are likely to suffer from ovarian hyperstimulation. I have had experience of managing a few cases many years ago, and those were critical cases actually, some of them. And I'll just give a summary of that. Now, so far as ovarian hyperstimulation is concerned, number one, I have broken down the whole thing into a few headings. One is incidence. Incidence is variable, and in general population or general OPD, you may not come across any cases, but where IVF is being carried out in those departments, of course, the incidence will be higher in those patients who undergo IVF, because essentially it is an iatrogenic condition. Then not in all patients one would come across that. Some patients have greater likelihood, like those women who have polycystic ovaries, and then it is likely to be more common because of larger number of follicles. And then it's pathophysiology. Why does it happen? In that, if you are interested, I can give you an article which is a very long one, but that's only for basic scientists. There is said to be
Sir, ovaries are hyperstimulated by exposing them to follicle stimulation.
What are the chemicals which are vascular endothelial growth factor? That is said to affect the permeability of the vasculature. And in addition, the other mediators of inflammation, they also play some role, because of which there is shift of fluid from the intravascular compartment to so-called third compartment, which is the cavities, like the abdomen, resulting in ascites, or it can result in even hydrothorax or pericardic effusion. So that is what happens, and because of that, there is increase in hematocrit. There is a high
पागल है।
हाँ पुत्र, हेलो हेलो।
हेलो जी, आवाज आ रही है?
जी अभी आ रही है, वीडियो नहीं आ रही, आवाज आ रही है।
आ रही है आवाज।
हेलो इमरान भाई, आवाज नहीं आ रही?
and all that. So therefore, in severe cases, you have to involve other colleagues from other specialties. So this is about the gist of ovarian hyperstimulation syndrome. And if you know about this much, that should take you through the examination.
Excuse me, sir, I have a question, sir.
Ji.
So what would be the choice of intravascular fluid? Because the vessels, they're already hyperpermeable.
Very good. This is a very good question. इन्होंने सवाल किया कि what will be the choice of fluids? Is that so?
Yes,
What you actually want to ask is whether you would give crystalloids or colloids. यही बात पूछ रहे हो ना? तो आप बताओ मुझे कि क्या दो?
Colloids, thinking, but because already hyperpermeable है.
हाँ.
Or the bleaching.
So you have a case for giving colloids, but generally what we do is we replenish because it can result in this kind of raised hematocrit and shift of fluids can result in lowering of sodium and potassium levels may be a little higher. So generally we treat them with crystalloids. What you are saying is all right, that makes sense, that in such situations you don't want the fluid to escape out, but in these cases you support with crystalloids to maintain her electrolyte balance as well. And if need be, if that kind of aggravates situation, then you would resort to colloids. Can you name any colloids? बाकी लोग कोई बताएं? Maxil or albumin or ये वाला. Good. So this is a very relevant, very pertinent question, and on the face of it, as the situation is, one's choice should obviously be to administer colloids, but to offset the electrolyte imbalance and to correct that, generally we give crystalloids and volume and monitor by hematocrit and further electrolyte assessment. जहां तक मुझे याद पड़ता मैं तो ऐसे ही करता था नहीं लेकिन सवाल लड़की तुम अभी हाउस जॉब कर रही हो हाँ FCPS ट्रेनिंग MCPS तुम MCPS क्यों कर रही हो फिर FCPS क्यों नहीं कर रही
सर मैं ऑलरेडी इतना टाइम गुजर चुका है कि अब फिर टाइम नहीं
अच्छा क्वेश्चन पूछ रहे थे हाँ और कोई क्वेश्चन जी ये चैट पे क्या है कुछ है कोई देखें तो कोई क्वेश्चन हो तो all right I quote a few we'll come to that examination business. Well, I'll quote you a few of the cases that I saw in my clinic yesterday. There is this 34 years old lady who is para 3 plus 0. She had her last delivery 7 years ago. There are 2 cesarean sections and 1 normal delivery. The first was normal delivery. And now she is complaining of heavy menstrual bleeding, which reduced her hemoglobin 6.4 a few months ago. And then she had to have injectable iron. And after that, she was put on tablet norepinephrine acetate 5 milligram thrice a day, cyclically for 3 months, during which time her blood loss during menstruation that remained within normal limits, but she doesn't want to continue with that. And on ultrasound, there is suspicion the endometrium is regular, comparatively thin. There is suspicion of adenomyosis of the posterior uterine wall. Otherwise, the uterus is parasized. So what are the choices for her treatment? She has 2 boys and 1 girl. एज इज 34। आप इसकी ट्रीटमेंट ये बनाएं, ये केस है और उसकी ट्रीटमेंट आप this is a clinical scenario. You've been given this information, and at this point her hemoglobin is 10.5 grams. So which means that Primula 10 has taken care of her excessive bleeding, and she is 34 years of age. The uterus is not greatly enlarged. Endometrium is regular. 10. What are various options? She is not happy with the Primula 10. So this is one case. हाँ ये मैं बाकी भी ऑडियंस है, ये सारे अपनी आप इसका वो बनाओ मैनेजमेंट के क्या इसको करोगे आप, पेशेंट को ओपीडी ट्रीट करोगे, पेशेंट को दाखिल करोगे, पेशेंट को पहले क्या बताओगे, क्या समझाओगे, उनकी काउंसलिंग एंड एक्सप्लेनेशन टू द पेशेंट ऑफ द सिचुएशन and what are the various treatment options and what are the merits and demerits of those, and what would be your choice of treatment if you are to advise, because so many times the patient can ask you, doctor, you tell me what is the best treatment for me. So do you do that, or do you help the patient make that choice? Sometimes you have to make the choice and you have to tell that, well, in my opinion, this is the best treatment that you should have. Now, there can be difference of opinion about the well developed. Ultrasound shows a small uterus, 5.3 centimeters to 3.4 into 2.1 centimeter, and thin endometrium. But she gives history of withdrawal bleeding on oral contraceptive pill, which she took for the last 3 months. What investigations will you carry out to assess the situation, and how would you counsel the family, the mother of the patient and the patient? That in itself is a full scenario counseling of this. I would be very much interested in asking a candidate about the counseling, how the counseling is carried out. And the other scenario would be regarding the investigations and management. And what are the possibilities of our having a proper reproductive life? ये आप इनके आप जवाब अपने बनाएं और इनको आप उस तरीके से फिर डिस्कस करें अपने कॉलीग्स के साथ, आपस में मिल के बैठ के आप डिस्कस करें कि क्या कैसे है. Then there is a patient who is a doctor. She is 41 years old. She has a pap smear 3 months back. The pap smear shows that she had atypical cells. She is para 2 plus 0, having regular menstruation, and these findings were seen on a routine pap smear. She doesn't has an abnormal a history of abnormal uterine bleeding. How would you counsel that patient, and what would be your line of management? 30 years old woman, para 1 plus 0, with history of cesarean section at 29 weeks in her first pregnancy, resulting in early neonatal death. She presents now at 28 weeks with an abnormal glucose tolerance test and a blood pressure of 150 by 100. Outline her management. Or what's the carding on the chain? Then there is another patient who had a miscarriage. She is 28 years, one miscarriage, followed by a full-term pregnancy with a cesarean section. Then she had an ectopic pregnancy, for which she had salpingectomy. That was 1 year ago. Now she is afraid to have a pregnancy because she fears that she may have another ectopic pregnancy. So what are her chances of having another ectopic? 1, she has come to you for counseling regarding her future chances of having a normal pregnancy, an intrauterine pregnancy. A college student, 18 years old, complains of vaginal discharge with itching. She wants to know the cause of the discharge and wants to discuss with you the treatment. What questions will you ask her? And what kind of examination will you carry out? A second gravida with a history of previous cesarean section because of so-called cervical dystocia with a baby weighing 3.4 kilograms, is pregnant now for the second time and desires vaginal delivery. Now, I am not asking you to write it. You can jot down these points. What I am saying is that these are various clinical scenarios. Now, these will be, as I understand, these will be given to you, for example, these clinical scenarios will be given to you in the examination and you will be required to respond to them. I don't know whether it will be written or it will be in conversational setup that you will be discussing with the examiner. Now, the important thing is that you need to practice this amongst yourself. You should have one of your colleagues with you and you take this scenario and one becomes the examiner, the other becomes the candidate. And the person who is going to be examiner should need to, for example, read it up and all that. But then you time it. You give it a time of 12 minutes. I wouldn't even say 15 minutes. So 10 to 12 minutes, say 10 minutes. Because if you prepare for 10 minutes, then you can stretch it into 15 minutes if that is the kind of time that is given in the examination. So you consider that you have to, yes, role player. There will be role players also. There will be actors, etc., whatever. So what you do is that this is the question, like the one I was just telling you that now this is a patient who's, and this is the kind of short history. Then how are you going to counsel? How will you tell that what kind of investigations you will carry out? How will you assess her? And how are you going to tell what chances she has of a normal delivery? What are the risks? Now, it can be expanded into various areas. What are the risks of vaginal birth after a cesarean section? What are the chances of the rupture of the scar? And so on and so forth. मैं ज़्यादा बोल नहीं रहा क्योंकि उसमें जवाब भी आ जाता है फिर, लेकिन ये है कि उसका पहला बच्चा 3.4 किलोग्राम का है. Now she wants to, I'm not even referring to her height, I am not referring to her glucose tolerance test or result of that, etc., and presentation, जो भी है. आप उसको cervical dystocia करके करो तो तब और scenario बनता है. अगर मैं कहूँ कि the first cesarean section was carried out because of breech presentation, so it was elective. In one scenario, it's an emergency cesarean section that because of failure to progress. वो हुआ, और दूसरा है because of breech presentation. वो उसमें size बच्चे का वही कर लो, बाकी चीजें वही कर लो, तो वो variable उस तरह से different हो जाएगा. Then we only had a patient yesterday. She had her third pregnancy. Previous two were cesarean sections, and she came at 8+ weeks of gestation with a small amount of bleeding. On ultrasound, it was seen that the pregnancy was in the lower part of the uterus, close to the cervix, and it had its attachment with the cesarean section scar. She is O negative. Right? So she came at 4 p.m. O negative. She has bleeding. She has 8 weeks plus. Previous two cesareans. Or here. Another patient. She is 36 years of age. Para 2+0. First baby, male, has autism. Second is a girl. She has pancreatitis. The girl is 6 years old. Now she has excessive abnormal bleeding. On ultrasound, there are multiple fibroids in the uterine cavity, is distorted. 36 years of age. आज के लिए काफी नहीं सिनेरियो हो गया एक घंटा. Anti-D दिन पड़ेगा. Please don't write in Roman Urdu. I'm sure that you can write that you will have to give anti-D. You are going to be specialist doctors. Don't write this Roman Urdu. This is my request to all of you who are present in this forum. Now, what you can do is, we can have some kind of, well, why can't we have a forum or a platform by which all of them, they can, can we have this? They can respond to these scenarios and questions. ऐसा करें कि वो सबके submit हो and then we can respond to that. And the answer of this, now, if you want to practice it, मैंने आपको मुख्तलिफ scenarios दिए. Now, what you do is that you write about half a page answer to that. Half a page. वो नहीं है उस तरह से बड़ा लिखे कि आप एक लाइन पे 4 लफ्ज लिखो और 2 लाइनों पे 1 लफ्ज लिखो. ऐसा ना करो. आप उसको आराम से half a page, उसके पेज का जो A4 साइज का पेज half page. Then let me tell you also that should be like 300 words से कम. 250 words का आपका आंसर होना चाहिए maximum. वो आप करो. Let's do this exercise and we'll see what the responses, and then we can change that. मैंने आप offhand कह दिया कि 250. आप 250 तक ही रखो. इसका आंसर जो है उसको let us see what you do. So you practice it. These are the scenarios, these are the cases, and that is what you will, and you have to think about it immediately. And that, within that, आपको सवाल दिया गया, आपके पास 10 मिनट थे, ये सवाल आपने सुना, सवाल आपने 3 मिनट में सुना. Now you answer that in 7 minutes. ठीक है जी. Next time ये आप जरा organize करो.
इंटरैक्टिव भी हो सकता है. डॉक्टर रूपा कह रही थी कि 3 कैंडिडेट्स अगर ऑनलाइन भी करना चाहें तो वो शॉर्ट सिनेरियो आप डिस्कस कर सकते हैं.
बात ये है कि अगर आप एक सिनेरियो को डिस्कस करना शुरू कर दोगे तो फिर 1 घंटा लगा दोगे आप, क्योंकि एक का आप आंसर सुनोगे, दूसरे का सुनोगे, आप फीडबैक दोगे, फिर ये सवाल होगा, फिर वो सवाल होगा कि ये ना किया जाए, वो ना किया जाए. वो इस तरह से सबमिट करें, देखेंगे फिर क्या है. ठीक है ना. जिस तरह से मैंने कहा कि there can be more than one correct answers or responses, so there can be 2 treatments. And if you can justify a treatment with which I personally do not agree, or if I say that I will not do this, I will do that, then even if you can argue about it, then you pass. ठीक है. कल पूरी कुमरान scenario.
So वो लिखा हुआ scenarios given today will be discussed when. Next. Give a list.
Scenarios given today will be. You see, my request to you is that you, as I said earlier, that this is an exercise which you can best do with your colleagues, with your friends, online with others, and then you can, as I said, that we will try to establish a platform on which you can submit, and then I can give short answers to that, or I can give you my responses.